Good morning, everyone. Thanks for joining. We are going to give it a few minutes for folks to gather, and we will be starting soon. Welcome, everyone, and good morning. And thank you for attending today's webinar, Lessons for Avoiding Medicaid Fraud, Waste, and Abuse. And this presentation is for New Jersey durable medical equipment providers. I'm Melanie Donnelly. I'm an administrative analyst here in the New Jersey Office of the State Comptroller Medicaid Fraud Division. And today's training is specifically tailored for DME providers who provide services to New Jersey Medicaid members. Before anyone asks, yes, today's presentation will be recorded, and following the presentation, the slides you're about to see will be circulated to you through email, and they will also be available on the Office of the State Comptroller's website. We are presenting to you today in partnership with a number of New Jersey state agencies and key stakeholders of the New Jersey Family Care Program. And this includes members of the Office of the State Comptroller Medicaid Fraud Division, which again is the agency that I'm a part of, the Department of Human Services Division of Medical Assistance and Health Services, or DMAS, the New Jersey Family Care's Managed Care Organizations, the MCOs, and the Office of the Insurance Fraud Prosecutor's Medicaid Fraud Control Unit, the MFUCU. And before we begin, we first want to thank those of you who are enrolled as providers in the New Jersey Family Care Program and who provide services to Medicaid members here in New Jersey. It's very important work that you do, and we thank you for doing it. So a little bit of housekeeping before we get started and dig in. This presentation is intended for general educational purposes only. It does not replace your responsibility to seek professional guidance, observe the laws and regulations that pertain to your practice as a Medicaid provider, and exercise professional judgment. So running through the agenda and the goals for today, the goals are to help you better understand the Medicaid program's regulatory oversight structure, along with its compliance requirements, documentation requirements for payment, fraud, waste, and abuse obligations of providers, and last but not least, red flag areas and the consequences for non-compliance. If you have questions during the course of this presentation and you're seeking an answer to, please enter your written questions into the Q&A portion of Zoom. The chat's really reserved for the chit chat, the hellos, the goodbyes, but if you have a substantial question that you want a response to, use the Q&A. We will take all the questions back and we will respond to your questions in writing at a later date. So it's important to us that we make sure that we gather those. You can submit them anonymously, but again, to ensure that you get a response, it's helpful to have your name and your email address attached to that question. But again, anonymous questions, the responses will be posted on the website, on the OSC website, so you will be able to see a response whether or not you submit anonymously or with your direct email. So now that the housekeeping items are out of the way, we're going to dig in and we're going to start by briefly addressing what Medicaid is. So Medicaid is a jointly funded federal and state program which provides funding for medical costs and special services for eligible individuals. Participating in the Medicaid program is voluntary, but if you do want to participate, you need to know and accept and abide by the rules and regulations. And if you want to continue to participate, the continued participation does require compliance with regulatory requirements. Throughout the presentation, you might hear us say Medicaid or New Jersey Family Care. We might kind of use those interchangeably. New Jersey Family Care is the name of the Medicaid program here in New Jersey, which includes Medicaid, the Children's Health Insurance Program, or CHIP, Medicaid expansion, and also the Medicaid services which are provided through the state, as well as through the 5 Medicaid managed care organizations, or MCOs. So the slide that you see here provides an overview of the New Jersey state agencies and related entities involved in oversight of Medicaid. So it just gives you a little landscape. So starting on the left, the Department of Law and Public Safety houses the Medicaid Fraud Control Unit, and the MFUCU is the criminal arm of Medicaid oversight. Next, we've got the Department of Human Services, which encompasses the Division of Medical Assistance and Health Services, otherwise known as DMOS. And DMOS is the entity that holds the contract with the Medicaid managed care organizations, which you also see displayed on this side. The Office of the State Comptroller is an independent state agency and might not be as familiar to you. Within the Office of the State Comptroller is the Medicaid Fraud Division, which is the civil arm of Medicaid oversight. And we will learn a little bit more about these areas throughout the course of the presentation, but again, just want to give you a little landscape so you understand the general gist. And now I'm going to turn it over to Geraldine Molinari, who is the Director of Managed Provider Relations at the Division of Medical Assistance and Health Services.
Good morning. So just to provide a little bit more detail regarding how you as a provider can find regulations and follow the requirements, I'm just going to go over some of the resources and the essential information that you need to continually be aware of. So as Melanie said earlier, the Division of Medical Assistance and Health Services is a part of the New Jersey Department of Human Services. The division administers the Medicaid program, which is for individuals who meet financial that are assessed financially to qualify for the program and or other specific health needs. If we go to the next slide, this is the site for where all of the Medicaid regulations are posted and newsletters. It's a link that you as a provider, if you've enrolled with Medicaid already, you're familiar with, but it's something that you should always be using as a resource. As you can see, this site is maintained with critical state and federal regulations and website information. So if you were to click on the column on the left, you would be able to find the regulations specifically to durable medical equipment. Also, a couple rows below is the managed care contract and any public notices. In addition, as a provider, the way the Division of Medical Assistance communicates with providers is by publishing newsletters. So on the next slide, we outline the critical way that the newsletters are used to introduce new programs or services, even pending regulatory updates or program guidance. And they can be found at njmmis.com. And you see the visual. It's a little further down on the bar that comes up on the left on NJMIS. But you as a provider are responsible for seeing these and adjusting based on the newsletters. That is how we communicate. When you register as a Medicaid provider, you agree to follow all the guidelines, and this is how we make sure that they're communicated. There are alerts that Gainwell will send out, but we recommend that you as a provider make sure that your key staff are looking at this and checking regularly to see what newsletters are displayed and updated that may refer to your specific area of service. If we go to the next slide, then we get more into the nuts and bolts of what the Gainwell and will do as the fiscal intermediary for Medicaid. They are the entity that enrolls providers. And the 21st Century Cures Act in 2018 required that all fee-for-service and MCO enrolled providers submit a 21st Century Cures application to Gainwell Technologies, because the Gainwell is doing that on behalf of the state. And in the past, providers could enroll with MCOs, but they didn't have to register with the state. But now every provider that services a Medicaid member, whether it's through the health plan or fee-for-service, has to submit a 21st Century Cures application. And the application is available online at the NJMIS website, and you just pick provider enrollment applications, and the 21st Century Cures Act application is one of the options. Questions regarding provider enrollment go directly to Gainwell at the number identified there, and also to their email. And after you as a provider may enroll as a fee-for-service provider, you also have the option to reach out to the individual health plans to contract with them. And each health plan requires a separate contract. And you see the 5 health plans that are listed here, and you'll obviously hear from some of the representatives throughout this presentation. But as a provider, it is required that you work independently with each of them. There may be some differences in processes, and that is acceptable. They all are required to follow managed care contract guidelines, but they have different processes. So you have to work independently with them and follow and register in their portal and do the required processes that they identify. And also there's the possibility that you may reach out to health plan and they don't need a DME provider in your area, and they will say, we're not open for new contractees, and that is acceptable as well, as long as they have already satisfied network requirements. So now I'm going to turn it over to Cassandra Epiphany in the State Comptroller's Office.
Thank you. Good morning, everyone. My name is Cassie Thippany, and I'm the Supervising Investigator of the Provider Enrollment Unit in the Office of the State Comptroller's Medicaid Fraud Division. I'm going to talk a bit about CMS's designation of high risk. CMS assigns risk categories to most provider types based on certain factors. The categories include limited, moderate, and high risk. The factors that impact the assigned risk categories include the provider or the supplier type, whether the provider is newly enrolling or revalidating, previous history with Medicare, such as past sanctions, exclusions, or disciplinary actions, and ownership and management. The category a provider type is assigned impacts the level of scrutiny during an enrollment or revalidation review. Durable medical equipment is part of a grouping of providers, which includes durable medical equipment, prosthetics, orthotics, and supplies. DME is a high-risk provider type. So what can a DME provider who wants to enroll in Medicaid expect? Here in New Jersey, all Medicaid applications for CMS-designated high-risk provider types are reviewed by the Office of the State Comptroller's Medicaid Fraud Division Provider Enrollment Unit. These reviews are conducted on behalf of DMOS through an MOU. An eligibility screening consists of a thorough review of the application, including ensuring that neither the entity nor the individual owners, managing employees, officers, directors, or board members are excluded or debarred. MFD also conducts an on-site visit for all high-risk providers, and the final step is a federal background check, which is conducted through fingerprinting. All individuals with an ownership interest, either direct or indirect, of 5% or more, will be sent for prints. If there are no individuals who meet that condition, then the managing employees are sent for printing. And now I'm going to pass it on to Angelica.
Hi, good morning. My name is Angelica Miranda. I am a senior manager of network contracting at Aetna Better Health of New Jersey. And today I'm going to go over the specific requirements to participate with the MCOs. So participating with an MCO will allow your group to provide services that are eligible to New Jersey Medicaid members enrolled with that specific plan. And there are two main parts to this process. First, the provider credentialing and also provider contracting. So first is the provider credentialing, and credentialing is the way in which the MCO can verify that the provider has all the required documentation to participate. It ensures quality, compliance, and accountability. So the following slide outlines the requirements for credentialing. So first, there is the application. It's a detailed application form that collects all the necessary information for the provider. Also required is proof of valid and current business license, along with evidence of current liability insurance coverage. A W-9 with the federal tax identification number and mailing address, and also the New Jersey State Medicaid ID is required. So the next piece is the provider contracts. The contract makes you a participating provider with the MCO, allowing you to provide services to eligible MCO New Jersey Medicaid members. The first step is the contracts are prepared by the MCO and sent to the provider. The provider reviews the contract terms and signs the contract. And then once the provider returns the signed contract, the MCO will countersign the agreement for and execute it. So once the entire credentialing package, including the signed contract from the provider, is complete, it is submitted to the MCO credentialing department for review and processing. Now, the process typically takes anywhere from 60 to 90 days to complete. However, you would need to consult with the MCO for their specific timelines. And I'm going to hand it over to Dr. Kumar. Thank you.
Hi, good morning. My name is Puneet Kumar. I'm a physician specialist with the Department of Human Services, Division Medical Assistance and Health Services. So today I'm going to be talking about documentation, billing guidelines, and records retention. Next slide. Next slide. So in New Jersey, prior authorization, when done through fee-for-service, is generally required for items over $300 that are considered as durable medical equipment, and then for medical supplies, items over $100. Incidentally, the division will be moving over to making that rule for supplies items over $300. So in other words, we are moving toward the future to have prior authorization only required on medical supplies costing over $300. But as of this moment, the requirement is still prior authorization required on supplies over $100. So that change will be happening sometime in the future. And then if medical HCPCS codes do require a prior authorization shall reflect decisions based on medical necessity and or the options of either purchase or rental. Next slide. Okay, so what is the process? So in general, when a prior authorization is required, the prior authorization shall be obtained from the appropriate medical assistance customer center, or MAC for short. And if you look on the bottom right-hand corner, we have 4 MACs located throughout New Jersey. We have one in Camden, in Newark, Freehold, and Patterson, representing the breadth of the entire state. So in general, prior authorizations shall be obtained directly from each of these 4 MACs. However, with the exception of the following. And we have these specific situations and circumstances noted below. So for example, prosthetics, orthotics, specialized wheelchairs or equipment, ventilatory and intermittent positive pressure machines, IPPMs, or hospital beds or pressure reduction mattresses, total parenteral nutrition, facility requests such as coming from nursing homes and ICF-DDs, and augmentative communication systems. So when it's when a prior authorization is required from these 6 particular circumstances, next slide. So on those individual 6 situations, then prior authorizations do need to be either mailed in to this address shown below, or they can be faxed in to that fax number noted here. And then the reason for that is that those 6 items just require more careful attention and just medical review. Okay, thank you. Next slide. As far as a physician order, and this holds true for both fee-for-service and prior authorizations that are being dealt with through the MCOs, the managed care organizations. So medical supplies and equipment require a legible dated prescription or a certificate of medical necessity personally signed by the prescribing practitioner. And this will be explained in more detail on next slide. Okay, so what are the actual required elements either for a prescription or that certificate of medical necessity? So we need the following information. We need the beneficiary's information, the beneficiary's name, address, and their Medicaid New Jersey Family Care Eligibility Identification Number. We need description of the medical supplies or the durable medical equipment that's being prescribed. And we need specifically the item type and the style. And again, being specific is very important. So for example, it's not sufficient to say just a patient needs a wheelchair. Rather, we would need to know the specific type and exact style of the wheelchair. We also need to know the duration, the length of time that that these elements are required. We also need to know the patient's diagnosis, the medical diagnosis, and a summary of the patient's medical physical condition that basically justifies the specific item being prescribed. As far as the prescribing practitioner, we need their name, their address, and their signature. And then under specific situations and circumstances, other information may be required from time to time. And again, refer to the guidelines, the specific statute shown on the slide for more information. Okay, next slide. Now, as far as prior authorization that are going through each managed care organization, so these authorizations can be obtained through specific forms or through provider portals that are specific to each managed care organization. And it's important to note that for the managed care organizations, prior authorization requirements can vary based on the specific medical item or the specific dollar amount of the item. And then on the next slide, we're going to show specific forms and provider manuals with links. Go to the next slide. Okay, so here we have each of the 5 managed care organizations. And if you follow these links, you would get their specific provider manuals. And then on the right-hand side, we have the prior authorization forms specific for durable medical equipment. So if you follow those links, you would get prior authorization forms, again, for a specific DME for each MCO. Next slide. Now, as far as proof of delivery, so MCOs can confirm delivery through retrospective reviews or through care manager roles or through member outreach. And proof of delivery can be made specifically, can be made available upon request. Okay, and that's the end of my presentation. And now I pass it over to Cesar Anikama with Horizon. Thank you.
Hi, good morning. Sorry, I was just trying to find the mute button. Good morning, everyone. Welcome everyone. My name is Cesar Anikama. I'm the ancillary contracting manager for Horizon. Today, we'll explore the essential billing guidelines applicable to both fee for service and managed care organizations. As healthcare providers, understanding these guidelines is crucial for essential accurate billing, compliance with regulations, and ultimately delivering high quality care to our patients. Go to the next slide, please. Second. This slide, we're going to discuss billing guidelines for fee for service and MCO, establish Medicaid NJ Family Care Fee Schedule, bill electronically using HIPAA compliant code for product provided. No established fee must apply one of 2 items with the bill. As you can see below, it's the manufacturer supplier invoice. It should contain the addressee, item description, and quantity and cost. Must be on a proper letterhead as well. You see to the right, the NJ Medicaid maximum fee allowance should include the manufacturer's name, item description, and suggest retail price per unit or package. It must include number of units per package if not described by the manufacturer. Next slide, please. As we continue the billing guidelines, claims will pay based only on eligible charges. Under the New Jersey law, claims must meet the following criteria. As you can see below, healthcare provider must have an eligible date of service. Person receiving service must have must be covered on date of service. The claim is a covered service supply benefit, and the claim is submitted with all required information in accordance with Section F of PL 2023. The payer has no reason to believe that the claim was submitted fraudulently. And if we can go to the next slide, please. Okay, this is billing guidelines rental reimbursement for fee for service. See below, medical equipment item, max fee allowance is $100 or less. Monthly rental payment is the amount billed, or 20% of approved purchase price, whichever is less. 6 such payments shall be deemed the full purchase price. No further payments shall be made, and the equipment will be considered the property of the state. For medical equipment item max fee allowance more than $100, the monthly rental payment is the amount billed, or 12% of the fee, whichever is less. 10 such payments shall be deemed to the full purchase price, and no further payment shall be made, and equipment will be considered the property of the state. Next slide. Okay. If the purchase of the rental is authorized prior to the close of the maximum rental period, a final payment will be made, which equals the difference between the sum of the prior rental payments and maximum fee allowance. If death, ineligibility, or other circumstances over which the New Jersey Medicaid has no control, rental fees for any medical equipment item shall terminate at the end of the month. Such circumstances occur and no further payment will be made. Next slide, please. And then the rental reimbursement, cap rentals vary by MCO. Aetna and Horizon follow the FFS guidelines. Fidelis, they follow the CMS guidelines. United and WellPoint considered other at the current moment. As we continue with billing guidelines, fee-for-service and MCO, all services rendered must be submitted on a CMS 1500, HCFA 1500 version, or UB04 claims form, or via electronic submission in a HIPAA-compliant 837 or NCPDP format. Claim forms and electronic submissions must be consistent with the instructions provided by CMS requirements as stated in the CMS claims manual. Next slide, please. Balanced billing. If a provider receives a Medicaid fee-for-service or managed care payment, the provider shall accept this payment as payment in full and shall not bill the beneficiary or anyone on the beneficiary's behalf for any additional charges. Records retention. To retain individual patient records for a minimum period of 5 years from the date the service was rendered. If contracted with Horizon New Jersey Health, HNJH requires record retention for the later of 10 years from the date the service was rendered or after the final payment is made and all pending matters are closed. And I'm going to get this over to Tracy.
Hey, good morning, everyone. My name is Tracy Livingston, and I'm the Assistant Director for the Data and Fiscal Area over at the Office of State Controller Medicaid Fraud Division. Next. So today we're going to talk about what is MFD. And Melanie mentioned this a little bit in the beginning, so I'm just going to go into a little bit more so you know a little bit more about our office. The New Jersey Medicaid Program Integrity Protection Act established the Office of the Medicaid Inspector General to detect, prevent, and investigate Medicaid fraud and abuse, recover improperly expended Medicaid funds, enforce Medicaid rules and regulations, audit cost reports and claims, and review the quality of care given to Medicaid recipients. These functions, powers, and duties were later transferred to the Office of State Controller and are carried out by the Medicaid Fraud Division. As Melanie mentioned earlier in her presentation, we are the civil arm of Medicaid fraud, fraud, waste, and abuse. Our job is to make sure that we monitor the program. I'm going to talk a little bit about that more as we go throughout my slides. And we also have a criminal arm, which we're going to talk about it later in the presentation. Next slide, please. Program integrity oversight. This refers to the system of monitoring and auditing New Jersey Medicaid providers to ensure that they're billing Medicaid accurately, delivering the appropriate services, not engaging in fraudulent practices, abusive or wasteful practices, and properly documenting the goods and services billed. A lot of these all of these bullets here on this slide are very, very important, and we take it very important with our work, especially making sure that you're building the program accurately, because we want to make sure that you're aware that when it comes to fraud, waste, and abuse, it's intentional or unintentional. So one of our goals for this presentation is to make sure that you're aware of that, and that you're aware of what the responsibilities are for you from a provider standpoint. Next slide, please. MFD oversight functions from program integrity oversight. So again, we're here to enforce Medicaid rules and regulations. So it's just important to note here that we don't do the rules and regulations, but we enforce them. So that's really important to remember from Medicaid Fraud Division. We also audit and investigate potential fraud, waste, and abuse by providers and recipients. And we also wanted to make sure that we noted here recipients, because we see that within our work as well. So we look at it from both of those positions. We also recover and properly expended Medicaid funds. This is something that's really important that our office does, as each of us as New Jersey citizens, we pay taxes, and a large amount of our taxes goes to the Medicaid funds. So every dollar that we recover, we're recovering that money that's going back to the state, which is spending your tax dollars in a more responsible way. So that's something that we really take seriously when we recover funds, because we're bringing money back into the program. We also coordinate program integrity functions but among various agencies. As you can obviously tell on the seminar, we work with the MCOs, we work with other state agencies, we work with the Medicaid agency directly. We also work with agencies outside of the state when it's necessary, and we also work with our federal partners as well. So we work with a lot of different agencies, and part of our goal is to get enough information that we can pull everyone together, and that we can get a positive outcome for the citizens of the state. The other thing that we also do, and this is also very important, we exclude or terminate providers of the Medicaid program where necessary. This is a very important function that we do for various reasons. The first reason, when services are provided to Medicaid recipients, we have to make sure that from a fraud, waste, and abuse standpoint, especially from an abuse standpoint, that the services that they're getting, that they're safe, that they're not being abused. We want that's something our office takes very, very seriously. And if we come across a provider that we think that's going on, we take the appropriate steps, which includes terminating those providers out of the program. You as providers, this benefits you, because if you have bad actors in the program, they're basically providing services they shouldn't to Medicaid the recipients. And it also affects your work because you have a bad actor in the program. So that's one of the functions that we really take seriously, making sure that we get those bad actors out, so that the recipients can get the care that they deserve. And for the most part, for most of the providers in the program, you can be proud of the services that you're providing, and that you don't have bad actors in the program. Next slide, please. Why is PI oversight important? Again, as I said before, it's really important because we're protecting Medicaid funds. Every dollar that out of your taxes that goes to Medicaid, you want as a taxpayer to make sure that those dollars are being spent appropriately. You want to make sure that the provider quality of care to individuals is going appropriately as well. For example, if you have someone in settings like home cares and nursing homes, those are very vulnerable recipients, and we take that task to make sure that they're getting proper care very, very seriously. And again, when we maintain the quality of care, we want to make sure, again, that it's not just about claims being paid properly. We want to make sure that the recipients are getting the quality care that they need. Consequences, and I touched upon this a little bit. Non-compliance with Medicaid rules, standards, and regulations regarding services may constitute acts of fraud, waste, and abuse of Medicaid funds. And here I want to stress again, I mentioned earlier that it's knowingly or unknowingly. So you want to make sure that you're looking at your billing practices. You want to make sure that you're looking at your staff. You want to make sure that and anything that someone in your organization are doing services, or you want to make sure that their licenses are intact. You want to make sure that they're up to date with the training. You want to make sure that you check all those things because you as a provider, you're responsible for that. And again, our goal is to look at all those things and to make sure that everything is happening properly when it comes to the spending of Medicaid funds in the program. Next slide, please. So I'm going to turn the presentation over to Kia O'Neill, and thank you very much.
Good morning. My name is Kia O'Neill, and I'm the Assistant Division Director over Investigations for the Medicaid Fraud Division. I will be discussing the Medicaid Fraud Division, actions and eligible providers, self-disclosures, and third-party liability. Next slide. MFD recovery actions. When an overpayment is identified as a result of an audit or investigation, MFD initiates actions for recoupment of the improperly paid funds. This does include sending a notice of overpayment. It may include a notice of intent and a notice of claim. MFD may add penalties, including false claim penalties per claim. And these penalties range between $13,946 and $27,894. MFD may also seek to withhold future Medicaid payments until the overpayment is satisfied, and may file a certificate of debt on real estate property owned by a provider or an owner of a business. Next slide, please. Ineligible providers. An ineligible provider is someone who is excluded from participation in federal or state-funded healthcare programs. Debarred, disqualified, suspended, or excluded providers are considered ineligible providers. Please remember that any products or services that an ineligible provider directly or indirectly furnishes, orders, directs, manages, or prescribes in whole or in part are not eligible for payment under those programs. Providers are required to perform ineligible provider checks upon hire and monthly thereafter. All of this information can be found in the NJMMIS newsletter, volume 33, number 22. You can find that newsletter on the NJMMIS website. Next slide, please. Per the newsletter, providers and MCOs are required to verify that any current or prospective employees, regular or temporary, contractors or subcontractors, are not excluded, unlicensed, or uncertified by searching these databases on a monthly basis. Next slide. Self-disclosure. Providers who find problems within their own organizations must reveal those issues to MFD and return inappropriate payments. The link provides information on when and how to self-disclose Medicaid waste, fraud, and abuse. The Affordable Care Act and the New Jersey Administrative Code require that any overpayments from Medicaid and/or Medicare must be returned within 60 days of identifying that they have been improperly received. Providers who follow the protocols for a proper self-disclosure may avoid imposition of penalties. MFD may extend other benefits to providers who in good faith participate in a self-disclosure process, such as forgiveness or reduction of interest payments for up to 2 years. Below you will find the link to MFD's self-disclosure form. Next slide. Okay, so what do self-disclosures, what must they include? So once a provider determines disclosure is warranted, an initial report should be prepared, which includes gathering the following information. So you must have the name and contact information of the individual making the report on behalf of the provider. You also should have a summary of the identified issues, including the underlying cause. So this includes what happened. It could be billing for services not rendered, missing or insufficient support documentation, improper coding or upcoding. You should also detail why it happened and how it happened. It should also include the Medicaid program rules potentially implicated. Was there a violation of guidance from a newsletter, of a policy? You should include the nature and extent of any investigation or audit conducted to identify and determine the amount of overpayment. So doing that, you should provide the names and titles of the individuals who were involved in the error or matter that occurred. You want to make sure that you describe completely and fully how the error or matter was found, including the names and titles of the individuals who discovered it. You should describe all the actions taken to stop the error or matter, including the names and titles of the individuals who are involved in rectifying the problem. You also must provide an Excel file, including a detailed list of claims paid that comprise the overpayments. You should provide an attestation of accuracy and completeness, all corrective actions taken to prevent reoccurrence of the error or matter, including the date the corrective actions were put in place. Next slide. Self-disclosure, statistical sampling and extrapolation. If the self-disclosure involves statistical sampling and extrapolation to determine the overpayment, the provider must prepare a report of its findings. The work must be performed by qualified personnel. At a minimum, the Excel file must contain the sampling plan, the universe and sampling frame, the sample with the results of the sample review, random numbers, and the seed number. The random number is what's used to select the random sample, and the seed number is needed so that we can replicate the sample. The extrapolation methodology and output, and the explanation or description of all software used to determine the sample and extrapolation. Next slide. Self-disclosure resources for sampling and extrapolation. So this slide lists resources for conducting sampling and extrapolation to determine the overpayment. Next slide. Third-party liability. Third-party liability exists when an entity or party is or may be liable to pay all or part of the cost of medical assistance payable by the Medicaid program. For example, Medicare, commercial health insurance, or TRICARE. TPL ensures that per federal and state Medicaid guidelines, that Medicaid is the payer of last resort. By law, Medicare is the payer of last resort. All TPL shall, if available, be used first and to the fullest extent to pay claims before Medicaid, New Jersey Family Care pays for the care of the Medicaid recipient. It is a violation of the Federal Social Security Act to refuse to furnish covered services to any Medicaid beneficiary because of a third party's potential liability to pay for services. Below, you'll find the numbers for the TPL hotline in English and also in Spanish. And now I will turn the presentation over to Brittany Sichel.
Thank you, Kia. As she indicated, my name is Brittany Sichel. I am with the Special Investigations Unit with United Healthcare, and I will be discussing today what is fraud, waste, and abuse. As per the cited statute here, fraud can be defined as an intentional deception or misrepresentation that's made by a person with the knowledge that that deception could result in some type of unauthorized benefit. Waste is usually considered a legal violation for civil purposes, and it can result in an overpayment, recovery of an overpayment, debarment from the Medicaid program, and other penalties, and is not usually considered a criminal act. Using the same statute, abuse is defined as provider practices that are inconsistent with proper sound fiscal, business, or professional or service delivery practices. And these practices can result in unnecessary costs or improper payment by Medicaid, or reimbursement for services that are not necessary, that are not approved, not documented, or those that fall outside of what was specifically authorized. Next slide. Here we have a list of some examples of what would fall underneath the fraud, waste, and abuse descriptors. So for fraud, anything where you're billing for services that are not rendered, billing for services while a member is inpatient, or transportation time being used as time spent on site. In comparison, waste we see with overutilization, misuse of resources, overuse of supplies, or billing for services that are not medically necessary. And here for abuse, we have services billed that exceed the prior authorized approved amount. Now, there are some business practices that could result in waste and abuse rising to the level of fraud. A couple of examples could be providing services without a proper authorization. This, of course, doesn't include situations that are considered emergencies. Using unlicensed, unqualified, or untrained staff, inaccurate or incomplete documentation of service, billing for undocumented or unsubstantiated services, or having insufficient internal checks and balances in place. Next slide, please. So here we have some of the consequences that could result based off of Medicaid fraud, waste, and abuse. We have civil judgments and liens, exclusion from the Medicaid or Medicare programs, referral for criminal prosecution, possible restitution or recovery of the identified overpayments, and additional penalties in addition to having to repay back those Medicaid overpayments. So now I'm going to pass this over to Haley Everson with WellPoint. We'll go over a couple of red flags and case examples.
Thank you. Good morning. My name is Haley Everson. I am the manager for our Special Investigations Unit. Next slide, please. A couple of red flag areas we're going to touch on. The first is misrepresentation of services. This can be when you're miscoding, stating that one particular service or product was given when it was actually a different service or product. A red flag for this particular issue would be a change in diagnosis code for a non-coverage service in an attempt to get coverage. And an example for this particular issue could be supplying an off-the-shelf product when you build for a custom fit product and misrepresenting what was actually supplied in your billing. Next slide. Next, we have upcoding. This is charging for a more expensive service or device than what was provided. The red flag for this is claims data analysis of outlier providers. And an example would be billing a miscellaneous code where there is a more appropriate code. Or, in this instance, an example could be, billing for a custom fit orthotic or a custom fit brace when an off-the-shelf item was actually delivered. Next slide, please. Next, we have billing for services not rendered. So this is submitting claims for items that were never delivered. Red flag for this, member complaints, photocopied orders with repeatedly submitting a new date of service appended to the same order, same provider for a different member. An example for this particular red flag is maintenance charges for equipment where maintenance was never provided. No proof of delivery. A good historical case example in this particular red flag area would be, glucose monitors and catheters. Members call in and state that supplies were never ordered. The member was never diagnosed with this condition. They don't require the supplies. They never received any supplies, but they see on explanation of benefits that they've been charged and the supplies have been paid for. You can review claims data and identify pretty quickly that, excessive billing for catheters and diabetic testing supplies when the members don't have issues related to those pieces of equipment could lead right to billing for services not rendered. And the next slide, we have unnecessary and excess care. So supplying significantly more than is needed for reimbursement. Red flags for this would include, telemarketers outreaching members without any physician involvement, members requesting services online just based on advertisements and not physician visits, or a physician prescribing that has no relationship to the member, where the member's never seen the physician outside of this specific prescription. Again, urinary catheters, orthotic braces, diabetic testing supplies. An example, a historical case example for this particular red flag would be members receiving TENS devices that were never requested and never ordered, but they received them. A pattern for billing the same items for the same member on the same date of service every month, and consistently providing additional services when they weren't requested or ordered, but being reimbursed for those services. Next slide. Just a reminder for oxygen tanks and CPAP devices, please be very familiar with the policies and guidelines for these, including what is in the benefit plan, what the requirements are for the medical necessity of these devices, what the billing limits are. Is it based on number of months or purchase price? And then what codes can and cannot be billed together? What is a bundled service? What is separate and identifiable? That sort of thing for these two specific devices. Next slide, please. I believe this is where we turn it over to Michael Rosati.
Yes, thank you, Haley, and thank you everyone for joining. My name is Michael Rosati. I'm a sergeant with the Medicaid Fraud Control Unit for the state. And as Melanie covered way back on slide 10, our office, the Medicaid Fraud Control Unit, or MFUCU, is located within the Office of the Insurance Fraud Prosecutor, and that is part of the Attorney General's office's Department of Law and Public Safety. So our office is the criminal oversight entity for the state's Medicaid program. So our primary responsibility is to investigate and prosecute cases that involve Medicaid fraud. And we do this through prosecutors or attorneys known as deputy attorney generals. We also have investigators, both civil investigators and then detectives, sworn law enforcement officers from the Division of Criminal Justice. We also have nurses, nurse investigators, auditors, analysts, and a host of other support staff that help us in our mission to police the Medicaid system. So we handle a wide variety of cases, all with their own connections or nexus to the Medicaid program. So these cases can include allegations of physical abuse to beneficiaries, and with that also would include financial abuse or financial exploitation of certain beneficiaries. We investigate cases that involve fraudulent activities by providers against the program, fraud within the administration of the program, and fraud against other federal or state-funded healthcare programs, again, where there is some connection or nexus to Medicaid. So this is the most relevant statute, but there are several that apply to our typical cases. But healthcare claims fraud, which is referenced at the top there, under that statute, it's illegal to submit a false claim to the Medicaid program or an insurance company in order to be paid for healthcare services which were not actually received or provided. The offense is punishable by up to 10 years in state prison. In addition to all other criminal penalties allowed by law, a violator may also be subject to a fine of up to 5 times the amount of any false claim submitted. These also carry a potential suspension or debarment from government-funded healthcare programs and potential forfeiture or revocation of a professional license. So just some things to bear in mind. If you are a practitioner and you hold a professional license, you only need to submit one false claim to be convicted. Willful ignorance of the truth or falsity of a claim is not a defense. There is also a reckless standard where if you operate or submit the false claim with reckless indifference to a material fact, that still violates the statute. You can also be found guilty of healthcare claims fraud, even if your claims were not intentionally fraudulent. So just a case example. These cases do end up in the news. There are press releases. You'll see them pop up on NJ.com when those releases go out. This particular case that I'll be highlighting here involved owners of a medical supply store who were sentenced to prison for stealing over $100,000 through Medicaid fraud in their scheme. So in this particular case, an audit was conducted by an outside agency of Medicaid claims submitted by a DME company that was specializing in orthopedic footwear. During their on-site review, their auditors noticed that most of the shoes on display in that particular store appeared to be regular shoes rather than the orthopedic footwear that was expected to be present in the store. As a result of their findings, the matter was referred to our office for further investigation. So our investigation included patient interviews and examination of medical supplies provided by the DME company. DMOS also provided our office with an expert to examine the shoes that were actually dispensed by this provider. The expert concluded that most of the shoes reviewed were comfort shoes rather than orthopedic devices. The expert also noted an issue relating to the dispensing of regular stockings instead of the medical compression stockings that they were submitting claims for. So as I'm sure many of you know, certain DME items are reimbursed by Medicaid at cost plus a fixed profit. So these require invoices to be submitted to Medicaid as proof of the underlying cost. In this particular investigation, we identified the use of fictitious fabricated invoices. There was, fabrications and falsifications about item descriptions, payment amounts, and also included fictitious suppliers. So suppliers that didn't even exist were creating invoices for the purposes of this fraud scheme. You can go next slide. So the outcome in this case, the two owners pled guilty to second-degree healthcare claims fraud. They were sentenced to 3 years in state prison. Were also imposed a 8-year debarment from participation in any government-funded health insurance program, and they were ordered to pay $300,000 in restitution and penalties for the offenses. So the bottom line, the simple truth is that ignorance of the law excuses no one. It's the provider's responsibility to know the laws, rules, and regulations that affect their area of practice. And with that, I'm going to turn it back over to Melanie for a wrap-up.
Thanks, Michael. And thanks to everyone again for hanging on with us. So we've reached the end of our presentation, but we still have some helpful information for you to stay on to see. So the following slides contain contact information for the relevant state agencies and managed care organizations. These resources are available to you, so please do not hesitate to reach out if you have questions. This slide contains the fraud, waste, and reporting contact numbers and links. And this slide contains useful emails and contact information for the 3 state agencies that you heard from today. If you have questions and you did not enter them into the Q&A, you can send written questions to the email address that you see on your screen. I monitor this mailbox. I will collect your questions and triage them and work as hard as I can to get back to you within a reasonable time frame. So feel free to jot that down. I'll take a moment so that you can do so. And then before you go, we would love for you to give us very simple feedback. There's a couple of questions that you should be seeing on your screen. If you could please answer those, just let us know how we did. We would greatly appreciate that. And we are wrapping up earlier than planned today. So we do thank you again for participating and taking time out of your busy schedules to be with us today. Again, the slides and the recording will be circulated to all of you. So please keep an eye out. They typically will come within the next week or so. And we hope you enjoy the rest of your day. Thank you so much and take care.